Hey everybody, welcome back to Pathology. Today we're going to go into detail with the white blood cell cancers. So first of all, we're just going to go quickly through the white blood cell morphology. All of them can be multinucleated besides the lymphocytes. And the lymphocytes are the only cells that are around red blood cell sizes. Everything else is about larger. Plasma cells are the ones that are like polar, so the nuclei are going to lie within like a certain pole or a certain end. The monocytes are going to be your granulated sites, along with your eosinophils and basophils. Neutrophils are going to be the first to respond to any kind of pathogen, and the dull bodies can be found in them, and those are dilated basophilic remnants of the rough ER. So proliferative diseases are reactive or inflammatory diseases where there is a normal increase in blood leukocytes in response to pathogens. It could be bacteria, it could be allergens, parasite infections as well. And the first disorder is a leukemoid reaction, and this is a special type of leukocytosis where the total white blood cell count is going to be elevated, and the immature granulocytes are going to appear in the blood. So the immature ones are like very large, hypersegmented, as you can see, neutrophils. The LAP score is high. This is important to know. This will differentiate the leukemoid reaction from leukemia. The LAP score is an important factor for it. There is no organomegaly, so there's no splenomegaly, there's no hepatomegaly, and the dull bodies are going to be present. And then there is a shift to the left, which means that there are the immature granulocytes in the periphery blood. The leukoerythroblastic reaction is a different kind of leukocytosis where the bone marrow is infiltrated with fibrous tissue. So this is a sign of metastatic cancer. This leukemoid reaction is a type that is just reactive to, like a normal reaction to infection. The leukoerythroblastic is not. So this is a problem with bone marrow. And that reflects it in the dacrocytes that are produced and the myeloblasts, along with the immature red blood cell precursors. There is going to be a nucleated red blood cells, and there are these micromegakaryocytes. So these are the platelet precursors, and they haven't quite matured into their like larger size. So in this case, there is no increase in the LAP score. Leukopenia, the definition is just a decreased white blood cell count, and usually it's the neutrophils that are reduced. So in females, it should be from like 14 to 13% of your neutrophils, and in males, it should be about like 16 to 20. Agranulocytosis is a very severe form of neutropenia due to the reduced or ineffective production or an increased destruction of the white blood cells. Lymphopenia is rare, so this is a deficiency of the white blood cells in the lymph, and this only really occurs in congenital immunodeficiencies or advanced HIV infections. Okay, so a neutropenic bone marrow is when the bone marrow is full of fat cells, and it can be hypocellular in regards of the white blood cell or red blood cell precursors, or hypercellular, and it's going to be a sign of one of the cancers where the cells cannot escape. So it will be packed full of these cells, and they're all immature. So it depends on the cause of the disease. Like I said, the hypercellular is going to be caused by increased neutrophilic destruction and ineffective granulopoiesis. So in the periphery blood, the neutrophils are going to be destroyed by like the spleen or whatever, or by disease, and the bone marrow isn't able to release the granulocytes. So one of the signs is just the delayed maturation of the erythroblast. So this will be nucleated red blood cells. The complications of neutropenia is obviously the secondary infections, and that would manifest as the ulcerating, necrotizing lesions of like the oral pharynx, loss of teeth, malaise, chills. It's called a neutropenic fever. As you can see here, the causes would be, of course, either bone marrow disorders, sepsis, tuberculosis, hepatitis, along with chemotherapy. In the severe agranulocytosis, it's due to the sepsis, where the blood cells, or the white blood cells, will all be used up to defend the body from sepsis, and the release of the toxic material within the white blood cells in order to eliminate the infection is going to cause like a cytokine storm. Autoimmune neutropenia affects young children. They don't respond well to viral infections, but they are not affected by severe bacterial infection. We characterize it by the presence of a neutrophil-specific antibody. Okay, so lymphocytosis is reactive, where there's a bunch of like lymphocyte morphologies found in the blood smear, and usually it's caused by like infectious mononucleosis, or mono, where the Epstein-Barr virus will infect the B lymphocyte and elicit a T cell response. There is no treatment in general to the Epstein-Barr virus infection, or herpes virus, or cytomegalovirus. Like, we treat the virus, but in like response to the lymphocytosis, we just kind of let that self-regulate. The symptoms present as upper left quadrant pain that radiates to the left shoulder because it's affecting the spleen, icterus due to liver involvement, fever, and pharyngitis. The most serious complication is the splenomegaly. It can progress to a shattered spleen, and that is very, very, very hard to treat. Also, if the Epstein-Barr virus has infected this person for a long period of time, that can transform into B-cell lymphoma. Downy cells are these cells, and they're pretty common in an Epstein-Barr virus infection. We use that to identify the cause of the lymphocytosis. There is also paracortical lymphoid hyperplasia, and we also use a monospot test to test for the nonspecific antibodies and IgM. So in general, we give the penicillin not to treat the virus, but to treat the opportunistic infections. Okay, so chronic non-specific lymphadenitis is just the swelling of the lymph nodes, and it can be all sorts of things. Usually there is follicular or paracortical hyperplasia and sinus histiocytosis. So the histiocytes will infiltrate the sinuses of the lymph node. So in general, lymph node follicles will all be around the same size in a normal reaction to a plain old infection. There is a problem if they're not of the same size, so that is a sign of cancer. Like I said, there's a lot of like normal causes of lymphadenitis. So we want to check the mitotic index. If the changeable bodies are increased, that is a sign of cancer. The starry sky is a pretty clear sign of Burkitt lymphoma. And we will stage the amount of involvement to see if the cancer has metastasized, according to like the swelling of the lymph nodes. And we will biopsy the lymph node to determine the grading. So we want to see the amount of differentiation. As you can see here, these are the changeable body with the macrophages. So this is not a good sign. Here are the mantle cells. Here are the centroplasts, but it's looking a little bit disorganized. So in this patient, we need to keep an eye on them. Okay, so reactive lymphadenitis. Normally, this is an activation of the humoral immune response, and follicular hyperplasia will occur. That's when the large mantle zone is going to be full of the B cells. So look, this is a huge mantle zone right here. The pericortical lymphoid hyperplasia, on the other hand, is the activation of the T cells. So here's the pericortex right here. And it's going to show in the expansion of the interfollicular regions. So it's due to the presence of the activated T cells. The hypertrophy of the sinusoidal and vascular endothelial cells will occur, and those are going to be associated with the reactions caused by drugs, viral infections, some vaccines. So this is a pretty normal reaction. The histiocytosis, is like you can see the distension and prominence of the lymphoid sinuses, and that is the problematic sign. The rest are normal, like hyperplasia, as long as it's ordered, like here, like you can see there is still a differentiation. That's okay. But once the sinuses get involved, it's a sign that the lymph node is draining a lot, right? So it can be due to a massive infection, but more likely it's due to draining of cancer cells. So the endothelial cells, once biopsies, they're going to be very enlarged and hypertrophied, and there is a lot of macrophages that have infiltrated. Casein cancers are caused by the stimulation of a proto-oncogene, which is ABL, which is on chromosome 9. So it's the constant stimulation of the tyrosine kinase pathway. And this will increase the stimulation of proliferation and decrease the apoptosis. This is usually caused by cat-scratch fever, and this will cause the caseating granuloma. And if you remember from parasitology, the parasite of choice is Toxoplasmosis gonadi. So that's going to infect the cells, and then it spreads to the lymph nodes and cause this casein granuloma. But it's different from the other granulomas because usually granulomas are only made out of macrophages. In this case, they are also made out of leukocytes. So why is this problematic? Because in HIV patients, this is going to cause death. As you can see here, the stellates, the central stellate abscesses are it's like almost in a star form, as you can see here, and they are going to be filled with these palisaded epithelioid histiocytes. So it's going to enlarge and invade the lymphoid sinuses. Okay, so now here are the problems. In lymph node metastasis, first, the primary tumor is affected. So in general, the submental lymph node is going to be caused by oral cancer, and the cervical is going to be head and neck cancers. Axillary is breast, hilar are your lung cancers, and your mediastinal can be your lung cancers, your Hodgkin's lymphoma, along with the T cell leukemia. And the para-aortic lymph nodes, that would be either Burkitt's lymphoma or testicular lymphoma. And in the inguinal lymph nodes involvement would be the genital genitourinary cancers. So the primary tumor is going to be affected first, and as you can see here, here's all the follicular hyperplasia is starting to get disordered, and once they have ruptured through the vessels and it enters the circulation, it's going to metastasize. Okay, so bacterial meningitis is usually caused by a gram-negative bacteria, and it can start from the destruction of the suprarenal gland, which would result in the Waterhouse-Friderichsen syndrome. That is going to cause an acute adrenal hormone crises, and the continuation is going to continue into like Sheehan syndrome, where there is like necrosis of the pituitary stalk. And in this picture, as you can see here, there's all this hyperplasia, and more importantly, there's a lot of stuff here, and this is the subarachnoid space. This should be clear, this should not be so infiltrated. There we go. So in bacterial, not just bacterial meningitis, but in the Waterhouse, in the celiac or Berger's disease, the IgA is high. So it's going to result in the IgA nephropathy, where there is going to be nephritic syndrome, and that's due to the deposition of the IgA, and that is also going to manifest in the gut as diarrhea, dermatitis, and the hematuria, abdominal colic, and the rash because of the autoimmune aspect of it. In the thymoma, the B cells are going to be present in the thymus, which is not normal because only T cells should be in the thymus. So those abnormal B cells will make the antibodies against the acetylcholine receptors, and then that's going to cause the myasthenia gravis. The B cells can also make antibodies against blood and red blood cells in particular, and then cause anemia. Okay, so leukemia involves bone, lymphoma involves tissues. Usually there's a problem in the translocations within chromosomes 9 and 22. This is known as Philadelphia chromosome, and that can result in Bloom syndrome, Fanconi anemia, ataxia telangiectasia, and it's definitely associated with Down syndrome. The viruses that can cause any kind of white blood cell cancer is the HTLV1, Epstein-Barr virus, herpes, Kaposi sarcoma, and HIV, along with H. pylori. So also a gluten enteropathy will cause an intestinal T-cell lymphoma due to the constant turnover of the enterocytes. Precursor B cell cancers are generally acute lymphoid leukemia, and those are present in childhood. So they have an abrupt stormy onset, and the organs are going to be involved along with the CNS manifestation, and all of that is going to lead to the anemia, bone pain, and extensive bone marrow infiltration. So the risk factors is the PAX5 mutation, translocations between chromosomes 12 and 21, mutations in TEL, and the AML1 gene. The markers would be CD19 and CD10 because this is a precursor B cell. Precursor T cell cancers are rare. They're involved with the thymic lymphoma, and they really affect young men. So clinically and morphologically, it's basically the same as B cell cancers. So you get the features of neutropenia, thrombocytopenia, the aplastic anemia, so there's bone marrow involvement, and of course the enlarged cervical lymph nodes. So the risk factors would be the Notch mutations and the translocations between 9 and 22, 12 and 21, and 4 and 11. And because this is a precursor T cell cancer, the markers would be CD1, CD2, CD5, and CD7. In the T cell cancers, ferritin and LDH are going to be increased, and the uric acid is going to be increased as well, so these patients will complain of like joint pain. You also want to test the albumin level to see if there is like a low albumin due to the amount of proteins being catabolized to, make the cancer cells. So in these cancer cases, we want to give these patients vitamin A to bind to the RAR alpha receptors to make the cells mature. Problem with like the precursor cells, like they are not as functional as the mature cells, and they're just taking up space and using all their body's resources to be made. So we see them in these smudge cells along with these spherocytes and the erythroblasts. Okay, so you want to distinguish the acute lymphoblastic anemia versus the myeloblastic anemia because the therapy is different. You test the myeloperoxidase and Sudan black for the myeloblasts because they're positive for only the myeloblast, while the PAS is for the lymphoblast. Otherwise else, you can kind of like eyeball it. They are kind of similar looking though, in my opinion. I would have just used different stains. So chronic lymphocytic leukemia is when the B cells proliferate, and they're all involved in older patients, and they're chronic. And they're found more in males. And sometimes there is hepatosplenomegaly, but bone marrow is always involved. The chronic lymphocytic leukemia is basically the same as small lymphocytic lymphoma, but the difference is the degree of lymphocytosis in the peripheral blood and how many cell types are involved. So chronic lymphocytic leukemia is going to involve more blood cells or different types of cells, and they are going to be found more in the peripheral blood, while the small lymphocytic lymphoma is really going to be sequestered in lymph nodes. So when they spill out of the bone marrow, in both cases, the mantle cells and the prolymphocytes are going to be like present. And as you can see here are your little smudge cells, and here are they in the very pink color. And when we biopsy the lymph node, there's going to be an undifferentiated lymph nodes, and there are small lymphocytes mixed along with these prolymphocytes and these smudge cells. These prolymphocytes will like accumulate in nests as well, or proliferation centers. The prolymphocytes will make the autoantibody against the red blood cells and the platelets, and the markers would be CD23 and CD5. So it's involving both the precursor and the mature T cells. So there's going to be a problem with the common precursor, of course, and that can transform into the Richter syndrome, where there is diffuse large B cell lymphoma, and that is fatal. So in that case, with the mutations of CD23 and CD5, there is an overexpression of cyclin D, thanks to a translocation in chromosome 11 and 14. And what does that mean? That means that the cell cycle is able to bypass this checkpoint from a G1 phase to the S phase, and it forces that regulation to be bypassed. So there's going to be problems with the replication of DNA. There's problems with checking of DNA. It's just going to continue into the growth phase. So sometimes the chronic lymphocytic leukemia can be asymptomatic, or they present with a lot of non-specific complaints like fatigue and fever and rash, along with unexplained weight loss. Most of the time, luckily enough, there are some generalized symptoms such as the lymphadenopathy, along with kind of hepatomegaly or splenomegaly. And when you test the blood for the immunoglobulins, it's going to be low. It's hypogammaglobulinemia. And as the disease progresses, it's going to lead to the autoimmune hemolytic anemia due to the antibodies made against the red blood cells and platelets. So that's going to lead to the thrombocytopenia eventually. So both CLL and SLL can go through the pro-lymphocytic transformation and transform into the aggressive diffuse large B-cell lymphoma, which is unfortunately fatal. That's it for now. Thank you for your attention and good luck studying.